Back to the deep dive. So today we are doing some serious detective work. We're looking at a part of the body that I think for most of us is just, well, it's just there until it hurts. We're talking about the abdomen.
The engine room of the human body.
Exactly. And honestly, when you look at the source material we have today, these, clinical lab guidelines, the anatomical maps, you realize the stomach isn't just a stomach. It's basically a black box.
It is.
You've got all this vital machinery, digestion, filtration, waste removal, all packed into this tight space. And you just can't see any of it directly.
And that is the fundamental challenge.
Yeah.
You're operating blind. In almost every other part of the physical exam, what you see is what you get. But here, you have to interpret clues. You're relying on sound and touch to visualize what's going on through a muscle wall that is, actively trying to keep you out.
And that's our mission for this deep dive. We're going to try to demystify this systematic approach. Because looking at these notes, it's not just about poking a belly and asking, does this hurt? It really feels like a choreographed routine.
It absolutely is.
Where the order of operations matters more than anywhere else.
Oh, for sure. It's one of the few places in medicine where getting the sequence wrong doesn't just get you bad data.
Right.
You can actually create false data.
Yeah.
You can manufacture symptoms that just aren't there.
That is wild. So I'm going to play the eager learner here, and I want you to be the clinical instructor, walking me through the why behind all these really strict rules.
I'd be happy to. The why is what makes it stick.
Okay, so let's set the stage. I'm looking at the preparation checklist in the source material, and it's surprisingly long. I was expecting, wash hands, walk in.
Right.
But it feels like everything has to be just right. The light, the temperature, the knees. Is the abdomen really that sensitive?
It's incredibly sensitive, but not just physically. It's psychological. I mean, think about it. The abdomen is our most vulnerable area. We're wired to protect our soft underbelly.
Okay.
So if a patient is stressed or cold, their abdominal muscles just involuntarily tighten up. We call that guarding.
Like a shield goes up.
Precisely. The rectus abdominis muscles, the six-pack, they'll turn into a rigid wall of armor. And if that shield goes up, well, you can't feel an enlarged liver, you can't feel a mass. The exam is basically over before it starts.
So all this prep is really about getting the muscles to stand down.
It's about hacking the patient's nervous system.
Exactly. So let's look at the checklist. Lighting. The notes say strong overhead light. I kind of assumed softer light would be more relaxing.
It would be, sure, but it's useless for diagnostics. You need strong lighting, specifically tangential lighting so you can see shadows. Yeah, a small bulge from a hernia or a pulsating mass might only cast a tiny shadow. If the room is dim, you'll miss it completely. You also miss things like jaundice, that yellowing of the skin, which can be really subtle.
Okay, now here's a rule that stood out. Have client empty bladder before exam.
Yeah.
That seems like just a courtesy, but the notes say it interferes with palpation.
Oh, it's physics. A full bladder is a water balloon. It distends upwards and pushes everything else out of the way. So if you're trying to feel the lower abdomen, a full bladder just feels like a mass. It's confusing.
So you could mistake a full bladder for a tumor.
It happens more than you'd think. But beyond that, it's incredibly uncomfortable to press on a full bladder. You hurt the patient, they tense up.
And you get guarding.
Instant guarding. Game over.
Right. And then we have positioning. The sources are very specific. Supine position with arms at side. And then there's this pro tip. Pillow under knees.
The knees up maneuver. This is critical.
What does bending the knees actually do?
We'll try this. If you lie flat on your back with your legs straight, your lower back arches a little bit, right?
Yeah.
That stretches the abdominal muscles. They're under tension. But if you bend your knees, it flexes the hips and introduces slack into the abdominal wall. It turns the stomach from a tight trampoline into like a soft pillow that we can actually press into.
That makes total sense.
Okay.
Last prep item. The hands. Short fingernails, obviously. But warm hands. It says cold hands cause muscle contraction.
This is the fastest way to fail an assessment. If you touch a patient's bare stomach with cold hands, what happens?
They flinch.
They flinch. It's a spinal reflex. It happens faster than they can think. The muscles spasm.
And it takes a while for them to relax again.
Sometimes minutes. So yeah, you rub your hands together, run them under warm water, whatever it takes. You cannot be the ice hand doctor.
Okay, so the patient is comfy, knees bent, bladder empty, our hands are toasty. Now what? The source material has this grid over the body. 4 sections.
The quadrants, that's our map. Because, my tummy hurts is way too vague for a medical chart. We need coordinates.
And the map centers on the transumbilical plane, which is just a fancy way of saying the belly button, right?
Exactly. The umbilicus is the center of the crosshairs.
So we have the right upper quadrant, RUQ, left upper, LUQ, right lower, RLQ, and left lower, LLQ.
Yep. And sometimes we use midline terms too, like epigastric for heartburn issues or suprapubic for bladder problems. But the 4 quadrants are the gold standard for locating organs.
Okay, let's quiz this a bit, because the diagrams show specific organs in very specific neighborhoods. So if I'm looking at the right upper quadrant, the RUQ, what am I looking at?
The heavy hitter there is the liver. It takes up a lot of space.
Yeah.
You've also got the gallbladder tucked right under it, the right kidney in the back, and parts of the colon.
So if someone has pain there after a fatty meal.
You're thinking gallbladder immediately.
Okay, moving across to the left upper quadrant.
That's where the stomach actually lives. It's pretty high up on the left. You also have the spleen, the left kidney, and the pancreas is kind of running behind everything.
The notes mention the spleen is fragile.
Very.
Yeah.
It's basically a vascular bag of blood. If it's enlarged from something like mono, you have to be incredibly gentle. You do not want to rupture it.
Right. Then we drop down.
Yeah.
Right lower quadrant.
Ah, the famous quadrant.
Yeah.
What's the one thing everyone worries about with right lower pain?
The appendix.
Exactly.
Yeah.
The appendix is right there. There's a spot called McBurney's Point where pain is like, it's appendicitis until proven otherwise. But, and this is key, you have to think about reproductive organs. For a female patient, the right ovary is there. An ovarian cyst can mimic appendicitis perfectly.
And finally, the left lower quadrant.
That's mostly plumbing, the sigmoid colon. So pain there is often, diverticulitis or constipation. And again, you check the left ovarian tube, knowing what lives where, lest you turn "it hurts here" into a suspect list.
Okay, let's move to the action. This is where the notes get really emphatic. There is a golden rule of order. Usually you look, then feel, then listen. Right.
In almost every other body system, yes. Inspect, palpate, percuss, auscultate. That's the rhythm.
But the abdomen breaks the rule.
It goes rogue.
The source says, inspection first, auscultation listening second, and palpation third. Listen before you touch. Why is this so strict?
Well, think about what the gut is. It's hollow tubes moving gas and fluid around. If I start poking and prodding, if I palpate first, I am mechanically moving those tubes. I'm stirring the pot.
So if I push first, I'm creating noise.
You are creating artificial bowel sounds. You might stimulate a quiet bowel to become active. So if I listen after I touch, I'm not hearing the patient's disease. I'm hearing the result of my exam.
It's like disturbing a crime scene before taking photos.
That is a perfect analogy. You have to capture the baseline audio before you go in and mess it all up.
That's a huge takeaway. Okay, let's walk through the 3 phases in that order. Phase 1, inspection. The visual scan.
Hands off. Just look.
The notes give us the 3 S's to look for: size, symmetry, and contour.
Right. You're standing at the foot of the bed or the side, looking at the profile. Is it flat, rounded, or scaphoid, which means sunken in?
Let's talk red flags. The source lists asymmetry.
Asymmetry is a big concern. We're generally symmetrical. If one side is bulging, you have to ask why. Could be an enlarged organ, a tumor, a hernia.
And then there's distension. How is that different from just being heavy?
Distension is a tight, swollen look. The skin looks shiny. It's not fat. It could be gas, fluid, we call it ascites, or a bowel obstruction. The stomach looks like a drum.
The notes also flag pulsation, seeing the stomach beat like a heart.
That's a red alert. A little pulsation in a really thin person might be normal. But if you see a bounding rhythmic mass in the middle of the abdomen, you have to worry about an abdominal aortic aneurysm, or AAA.
That's the main artery of the body ballooning out.
Right. And if you see that pulsating, you do not go poking it deeply.
That's terrifying. One last visual, skin color. We talked about jaundice. But the notes mention bruising around the belly button. Cullen sign.
Yep. If you see a blue or purple tint around the navel, that's a classic sign of internal bleeding, often from pancreatitis. That patient is in serious trouble.
Okay, so we've looked, we haven't touched. Now we pull out the stethoscope. Phase 2, auscultation.
My favorite part, the abdomen is a noisy place.
The source mentions timing is everything. It says bowel sounds are loudest 5 to 6 hours after eating.
Yeah, that's when digestion is in high gear, but you should hear them anytime.
And the technique is to listen in all 4 quadrants. But what are we listening for? The text describes it as clicks or gurgles.
Yeah, it sounds like water in a pipe, little pops, or rocks tumbling underwater. It's very distinct.
And it says they are irregular.
That's key. It's not a heartbeat. It's random. It stops, starts, gurgles, stops. It's chaotic.
So in terms of frequency, what's normal? The source says every 5 to 15 seconds.
Roughly. You put your stethoscope down, you shouldn't have to wait long to hear something.
Okay, but then we have the abnormal findings. Let's start with hyperactive.
Hyperactive is like a pinball machine in there.
The source says greater than 2 to 3 sounds per second. That sounds intense.
It is. It's a continuous rushing sound. Yeah. We call it borborygmus, a fun word for stomach growling. You hear this with a stomach flu, but also in early obstruction.
Why early obstruction?
Imagine a kinked garden hose. The water pressure builds up and makes a loud rushing noise trying to get through. That's the high-pitched tinkle of an obstruction. The gut is fighting the blockage.
And on the flip side, we have hypoactive.
Quiet. Too quiet.
Yeah.
Less than 5 sounds per minute.
And what causes that?
This happens when the bowel is sleepy, like after surgery, anesthesia puts the bowels to sleep. Or with inflammation, like peritonitis.
And then the scariest one, absent bowel sounds.
Silence. The factory is shut down.
But there's a really strict rule here in the notes. You cannot declare sounds absent until how long?
5 full minutes.
That seems like an eternity in a clinical setting.
It feels like a lifetime. Try staring at a clock for 5 minutes without doing anything. In a busy ER, standing there for 300 seconds, just listening to silence, is agonizing. But you have to do it.
Why? Why not just a minute?
Because absent is a diagnosis that changes everything. It means stop feeding this patient, maybe prepare for surgery. It's a medical emergency. If you listen for 45 seconds, miss one tiny gurgle, and declare it absent, you might be sending them down a path they don't need. You better be sure.
So patience is a clinical tool here.
Absolutely. It's a test of discipline.
Okay, assuming we've listened, we finally get to touch. Phase 3, palpation.
Now we move in.
The protocol says, stand at the client's right side. Why the right side?
It's just standard practice for ergonomics.
Yeah.
The liver's on the right. It's the biggest organ we palpate. And reaching over the body to feel it is just awkward. You lose sensitivity.
And the technique described is light palpation.
Very light.
Use fingertips. Press down only 1 to 2 centimeters with a rotating motion.
You're not poking. You're making little circles with the pads of your fingers, not the tips. You're feeling for surface characteristics. Is the skin soft? Is the muscle tight? You aren't diving deep yet. That's an advanced technique.
The notes explicitly say, lift your fingers to move. Don't drag.
Dragging just feels awful. It's irritating. Lift in place. Lift in place.
Now, we need to talk about the painful last roll. This is highlighted. If the patient is hurting, palpate that area last.
This is psychology meets physiology. Imagine you have a bruise on your arm. If I walk up and poke that bruise immediately, what are you going to do?
I'm going to pull away and tighten up.
Exactly. You will guard. Your abdominal muscles will turn into a rock.
Mm-hmm.
And now I can't examine the other 3 quadrants. So we ask the patient, point to where it hurts, and then we start as far away from that spot as possible.
It's like a negotiation.
It is. You start in the safe zone. You show your touch is gentle. You build trust. Then slowly, you spiral in toward the painful area at the very end.
That requires reading the patient right. The notes say, observe for grimacing, guarding. You have to look at their face.
Always watch the face. Patients can be tough. They might not say, ouch, but their eyes will widen or they'll grimace or their breath will catch. The face tells you the truth.
And the expected finding is, abdomen is soft, non-tender, no masses.
Soft is good. Rigid is bad.
Let's define rigidity.
We call it a board-like abdomen. It feels like touching a wooden table. That's an involuntary spasm because the lining of the abdomen, the peritoneum, is inflamed. That's peritonitis, a surgical emergency.
So we've done the full circuit. We prepped, mapped, looked, listened, and palpated. What do we tell the patient?
We empower them. We tell them what to watch out for.
The notes list. Worsening pain, nausea, vomiting, or diarrhea.
Right. And changes in bowel habits. If the pain moves, like from the belly button to the right side, that's classic appendicitis. They need to know that's an ER trip.
And one last thing to ask the patient, which connects back to the start, when they last ate or drank anything.
NPO status?
Yeah.
Nothing by mouth. If we find something bad, that patient's probably going to surgery. The anesthesiologist has to know if there's food in the stomach. And it helps us interpret those bowel sounds too.
It's incredible how systematic this all is. Let's recap the big takeaways. Number 1, preparation is physiology. Warm hands, bent knees. It's not just comfort, it unlocks the abdomen.
Exactly.
Number 2, know your geography. The quadrants tell you who the suspects are. RUQ is liver, RLQ is appendix.
Right.
Number 3, respect the golden rule. Look, listen, then touch. Don't mess up the audio.
Mm-hmm.
And number 4, save the painful spot for the end. Build trust.
That's a perfect summary. It turns my tummy hurts into a structured scientific investigation.
It really does. It strikes me that even with CT scans and MRIs, so much of this still comes down to warm hands and a stethoscope.
It does. And I want to leave you with a thought on that absent bowel sound rule. We live in a medical culture that rewards speed. Everything is rush, rush, rush.
Yeah.
But the guidelines insist 5 full minutes of listening to silence.
It's a long time to stand still.
It is, but it raises an important question. Do we really take the full 5 minutes, or do we rush the silence because we're busy? That 5 minutes, it's a test. It's a test of the clinician's patience as much as it is a test of the patient's health. Sometimes the most important thing you can do isn't to cut or prescribe. It's just to listen long enough to be sure.
That is a powerful place to end it. Sometimes silence speaks the loudest. Thanks for guiding us through the black box today.
My pleasure.
And thank you for listening. We'll catch you on the next deep dive.